Hello, good evening, everyone. I am Mrinal Rai Madhav and working with SiteService India, based in Delhi. And on behalf of Vision 2020 India and Jamindar Microsurgical Eye Care Center, I would welcome you to this webinar on adverse event reporting culture in eye care organization. We will run the session for an hour. Vision 2020 India has been organizing various webinars under its Knowledge Hub initiative. Let me introduce our resource person. Dr. Samia Jamindar is founder and medical director of Jamindar Microsurgical Eye Center from 1997. Passionate about encouraging smaller uh, healthcare organizations to implement quality and safety standards, striving to serve patients and independent eye center trainees with excellence, global best technologies, processes, and expertise in eye care. She is MS DOMS ophthalmology from Gujarat University. She is trainer for facial emulsification cataract surgery during surgical skills transfer course organized by All India Ophthalmological Society since 2015. She is a certified professional for quality implementation in healthcare organization. She is also a member of South Asian Academy of Ophthalmology, member of Presidential Committee for Adverse Events of All India Ophthalmological Society, member of National Association for the Blind Karnataka chapter, member of the All India Ophthalmological Expert Group for Sterilization Protocols for Ophthalmic Instruments and Prevention of Endophthalmitis, member of the Government Council of Consortium of Accredited Healthcare Organization, CAHO. Uh, so with that, we will also like to thanks to Orbis CyberSite for providing us this CyberSite platform. We appreciate the support from our corporate advisory board members that include Appasamy Associates, Orolab, SLR Luxottica, Forus, and Microflow for their continuous support. For the audiences, the participants, there is a Q&A box where you can type your questions and we will answer them at the end of the presentation. So you simply, during the session also, if you have any query in your mind, you can simply type it, and towards the end of the session, we can have a Q&A session to have discussion on this. Thank you once again for your participation. Now, I would request Dr. Samia Jamindar to take on. Over to you, ma'am. Yes, it is.
So thank you so much, Vision 2020. Okay, all the office bearers at Vision 2020. I am Mrinalji, Gangadharji who helped me in the morning, Fanindraji who invited me for this meeting, and everybody at Vision 2020. I really appreciate your encouraging this particular culture, an adverse event reporting culture in eye care organizations. And I bring greetings to all of you here from my team at Bangalore. We all know that the very first requirement in a hospital is that it should do the sick no harm. I think Florence Nightingale taught us this long back. So why is it that medical errors are a leading cause of death globally? In low and low middle income countries, it is estimated that 5 persons die every minute due to unsafe healthcare deliveries. And then somebody might stop me and say, hey, but here we are talking about eye care organizations. So where is the question of death? You will be surprised to know that in a patient safety journal, besides the actual incidents of death in an eye care organization, which are brushed under carpet, it also says that ophthalmology is one field where adverse events like wrong patient, wrong implant, wrong eye are very common. And we need to figure out why is this still very common. We need to work together to develop an adverse event reporting culture in our organizations. So The first question which would come in our mind is that why are adverse events not reported? Why don't we report adverse events? In fact, in my tenure as an NABH assessor, I know that when I go to go for an assessment in the first time assessed hospitals, typically the adverse event they will report is really very less, close to zero, because the culture is not present. And the reason why adverse events are not reported are that we are not psychologically safe teams. So what am I talking about psychologically safe teams? Are the groups with which whom we are working, are we normally in a day-to-day life when our staff come to work, are we allowed to say things like, I'm not feeling like myself, I feel sad without any reason, maybe I'm depressed? Can we normalize all these things at our workplaces first? If we are able to do that, then maybe we can even talk about an adverse event reporting culture. In healthcare professionals, it becomes very difficult to take the stress and strain of a daily life with patients speaking very rudely to the staff. They talk differently to our staff as compared to how they talk to doctors. And how our staff suffer from that. Are they allowed to say these things? Then we come to an area where mental health gets affected much more in an adverse event, in a circumstance of adverse event. So when something goes wrong, what does typically happen in most of the organization? Naming, shaming, and blaming. But training does not happen. You name, shame, and blame. And this is completely counterproductive. An organization which wants to grow, thrive, and sustain has to stop this kind of a culture immediately. When an adverse event happens, of course, the patient suffers. But then the patient is the first victim. The patient's relatives are the victims because they suffer along with the patient. And who is the second victim? The healthcare professional who has been a part of this adverse event is the second victim. And there's a lot of mental stress and trauma, especially in any organization where there is no adverse event reporting culture. And I will very shortly come to that culture. The patient suffers, the relatives suffer, the staff suffer, the organization suffer, and everybody suffer. So you can imagine that proactively working towards an adverse event reporting culture can be the game changer, can make a win-win situation at all times. So what needs to be done? You need to remember that this healthcare professional, this second victim, what happens after an adverse event to the second victim? We all know what happens to the patient, and we'll talk about it a little later. But let's talk about what happens to the second victim. 66% of them cut back their efforts if they are now a part of a blame game. 12% leave their job. 80% lost work time. 25% develop worse performance, and 45% generate newer, fewer ideas. So how do we develop an adverse event reporting culture in our organizations? Isn't that the topic for today? How do we develop an adverse event reporting culture in our organization? The world around us, the people whom we work with, that world around us strongly influence our performance. if there is a feeling of respect, feeling of gratitude, feeling of loyalty, feeling of patient safety, then that your performance is affected strongly with those choices. Team psychological safety was coined by Dr. Amy Edmondson from Harvard Business School. He said that Dr. Amy said that once the culture is such that everybody feels strong together, they feel that if something goes wrong, I will not be blamed. It will be the system in which we are working will be blamed. So it is not that I made a mistake. It is not that I'm not a mistake. I made a mistake. I did something wrong, but I'm not a mistake. I'm going to evolve, learn from this mistake, and do something better. So when something goes wrong at work, instead of asking if you are the leader, you're not going to ask, what did you do? You're going to ask, what happened? This is the beginning of an incident reporting culture in your organization. You have detached the person from the incident and are ready to examine the entire ecosystem in which the error occurred. If your team feels respected, gratified, and are paid accordingly, they are more likely to follow protocols, admit mistakes, and learn from them. So remember, the question you would ask is, what happened? Not what did you do? It is not a person's mistake. It is the ecosystem in which they are working, which is at fault. So let's come out of this example of a healthcare system and let's go to the example of an aeroplane. We all fly, right? And is it safe to fly? Do you think it's safe to fly as compared to getting maybe treatment in an eye hospital, getting your cataract surgeries done at an eye hospital? I would say yes, it is, because in any aeroplane system, they follow the 6 sigma. That means that the chance of an error happening is 1 in 3 million opportunities. Now, then what am I saying here? I'm showing it to you that 80% of flights involve 1 or more errors. So errors happen, but they do not manifest into an adverse event. Why? Why does this happen? That's because they follow the Swiss cheese model, the cumulative act effect. That means there are multiple layers, there are multiple barriers for error propagation. There are multiple checklists which are followed. And if there are minor errors which happen, they really don't end up into an adverse event. The chance of an error that your flight will get crashed is 1 in 3 million. That's what is 6 sigma. We in eye care organizations are far, far away from a 6 sigma because we do not have enough checkposts, enough barriers. And then in the Swiss cheese, if these holes of the Swiss cheese, if they align one day, if the number of barriers are not enough, then you will end up with an adverse event. So you learn from this that you need to have enough and more barriers before an actual adverse event happen in an organization. So what are the barriers we are talking about? The barriers of standard operating procedures, the barriers of training, the barriers of monitoring, and last but not the least, the barriers of adverse event reporting. You learn from your adverse event and set preventive actions in place. So the Japanese say that a mistake is a treasure. A mistake is indeed a treasure. You need to learn from your mistake. How do you go about this? So where can we start? Where can we start this developing this new culture in our organization, an adverse event reporting culture? This gentleman, Dr. Lucien Leap from Harvard School of Public Health, told us that incompetent people are at most 1% of the problem. The other 99% are good people trying to do a good job who make very simple mistakes, and it's the processes that set them up to make these mistakes. So we as the leaders of our organization should work hard to make these processes very simple. And the most important thing is that understand what are the different kinds of adverse event. Do you think that an adverse event should be reported only if it results in a patient harm? What about something like a near miss, that an event that had the potential to cause harm but was prevented at the last minute, resulting in no actual harm? Or what about a no harm, that an adverse event actually occurred? You put a wrong intraocular lens, but the intraocular lens power was almost the same as the other person's lens, and it did not result in any harm to the patient. Would you want to report a near miss or a no harm also? Yes, my friends, I would want you to report all the near misses and no harms, because a near miss and no harm shows that already you had an adverse event. You were just lucky. That means already there was a fault in the system and the system needs to be corrected. This near miss or no harm, if a root cause analysis and preventive action was not taken, then will definitely result in an adverse event next time. Sentinel event, an adverse event that results in significant harm, such as physical or mental disability lasting for 3 weeks or more. These are known as never events. They should never happen in an eye care organization. An endophthalmitis, a death, they are all sentinel events. So let's start from this knowledge that eye does not see what the mind does not know. What does this mean? That means that the staff working in different departments should know what does an adverse event mean, what to report, and what are the probable adverse events in their department. For example, let's see the possible adverse events in the cataract department. Pre-operatively, what can go wrong? Intraoperatively, what can go wrong? Post-operatively, what? And what are the preventive strategies? So at each level, the staff needs to be trained so that they are proactively working towards eliminating any such adverse event at all points in their work or the duty. Now, how do we go about it? How do we make it easy to do the right thing and difficult to do the wrong thing? Isn't it very simple? Just make it easy to do the right thing and difficult to do the wrong thing. If you do that, things will sort out. You will have a more happier working environment because the number of errors will reduce. This gentleman, Professor Atul Gawande, he gave the gift of the surgical safety checklist to WHO and in turn to the entire world. We all have a surgical safety checklist in our operation theaters. Is it just a mere tick list, or a role play happens every time the patient is wheeled into the operation theater? A sign in, a timeout, a sign out? This is what is really needed. Actually checking at 3 points twice before the incision is put on the patient's eye, whether it's the correct patient, the correct eye, the correct implant, and the correct procedure for that matter. Easier thing what we have done in our centers is, instead of making long, lengthy checklist, we have made do not miss list, so that these are the most critical points of patient care, of patient safety. And these do not miss lists should be visible in all stations at the work. Do not rely on memory. Rely on simple list. That is very, very helpful. It has helped us, and I hope it helps all of you. Professor Liam Donaldson, the WHO envoy for patient safety, said that to err is human, to cover up is unforgivable, and to fail to learn from a mistake is inexcusable. So we should all be ready to learn from the mistake and do a root cause analysis and set preventive action. How do you do an incident analysis? There is an incident. There is a classification of the incident, a root cause analysis, a corrective action, and a preventive action. For example, patient develops severe itching and redness in eyes following administration of tropicamide and phenylephrine drops. You classify as an adverse drug event. It is not a near miss or a no harm, something harmed the patient. Root cause analysis, patient did not give any previous history of allergy to the drop. Corrective action, tear supplements or oral or topical antihistaminics. Preventive action, document previous history of known allergy to drugs in the red ink. If no known allergy found, mention the same. This looks like a very simple incident analysis, but there can be many layers to any incident. And our job is not to just cover up and do something as a compliance for any NABH or any such thing. Our job is to ensure that such an incident doesn't happen definitely in that patient, but it should not happen in any other patient also. These are some incident reporting forms which are available, which should be made available in your organization. Clear analysis of an adverse incident, and incident reporting form should be filled within 24 hours of an incident. If it's not filled within 24 hours, that becomes an incident in itself. So this is a kind of a fishbone analysis or an Ishikawa diagram, for example, of an undue post-op inflammation for cataract surgery, where we have man, material, methods, every single thing checked and taken care of. If there is an inflammation, that was an adverse event, the patient had to suffer, and why. This kind of ready fishbone analysis and Ishikawa diagrams have been made and put together in a wonderful resource by SEVA Foundation. And very shortly, you will have an access to this common resource pool of Ishikawa diagrams and 5 whys for common adverse events which happens in an eye care organization. So once they are available, I will inform Vision 2020, and I'm sure that all of you will get a copy of that. So the 5 whys analysis is that the objective is to keep probing until the genuine root cause looks to have been identified. The problem solution will then be verified to confirm that the root cause was identified. Why? The book 5 whys says that most of the root cause analysis you are able to find out if you ask the question why 5 times. Let's take an analysis for a wrong eye cataract surgery. Before incision, the eye was not confirmed. That was the first why. Why it was not confirmed? Documentation not clear on which eye to be operated. No protocol for clear documentation of findings. A new recruit who did not do it, or the training was not done during induction. And finding the actual whys, identifying the contributing factors, communication and information management, human resources, policy and procedures, leadership and culture issues, and the physical environment. Are you taking care of the hygiene factors for your people who work with you? Are they overworked? So these are the things which are of paramount importance when you're actually trying to find the actual why. Go into detail. Somebody who is doing this job has to definitely be in a senior leadership position. So the preventive action can be strong actions, intermediate actions, and weaker actions. The stronger actions would be simplify processes and standardize the process or the equipment. Strong action is a simplified process. So it goes back down to your standard operating procedures. That's very important. A weaker action would be to give warning to the staff. That is a very weak action. You understand? It's not a person. It is the ecosystem which is responsible. If your SOPs are so good, if you have standardization in your hospital, then the chances of errors are very less. Just by penalizing the person, you are actually not achieving anything. You are doing more harm. So training and monitoring is very important. Work as you imagine how managers believe work is being done. and work as performed, how the work is actually being done. So this gap has to be taken care of, and there should be the so-called Gemba walking. Managers should be actually coming out of their rooms and walking around and seeing how work is done. That is very, very important. Do not sit in your cozy rooms and think, oh, I'm sure this is happening, that is happening. No, you need to understand exactly how the work is happening. So we all unite and get equipped to fight, making new protocols, ensure that staff abides by them without the need of CCTV monitoring, adopt a culture of written down guidelines, ongoing training and monitoring. If this happens, the chance of errors reduce. And once error happens, if your teams are psychologically safe, if there is a culture of adverse event reporting, then the second victims are avoided. I would want to give you a good news that CAHO has come out with a white paper about patient-reported experience measures. Empower your patients to take care of their safety. For their cataract study, I was the principal investigator, and these are the few questions we ask our cataract surgery patients. Not just a regular feedback. This is a PREM feedback. And this white paper is freely available. I'm very happy to share it with all of you, which has these questions to be asked to your patients. Empower your patient. Learn from your patient whether they felt safe during their journey of cataract surgery. Were you informed about your present eye condition and expected improvement in eye condition? Were you explained about the surgical procedure and anesthesia before signing the surgical consent? Did the operating room team verify your name, hospital number, and eye to be operated before starting the surgery? Have you been advised about when and how to seek urgent care in case of any emergency? So this PREM tool, if you use in your, say, for example, this is for cataract, so in your cataract department, you will get to know how safe is your cataract department. What is the chance that an error can happen? Who better than your own patients to tell you how safe you are? So these are the principles of a safe eye care organization. First, humans are fallible and even the best can make mistakes. So remember that mistakes can happen, but it is your job to standardize, have checklists, have do not miss list, and have a psychologically safe team. Error-like situations are predictable, manageable, and preventable. So somebody in your leadership position should be looking at it and doing some amount of proactive risk reduction. Individual behavior is influenced by organizational processes and values. What is the organizational processes? Remember that when one adverse event happens and one person is blamed, at that time, all the onlookers, all the other staff who are around will decide in their mind that next time if I make a mistake, I'm not going to report it. Events can be avoided by understanding the reasons mistakes occur. Why a mistake happened, what was the ecosystem in which the mistake happened, how can you improve the ecosystem, not just improve the performance or warn the person who has made the mistake. So thank you very much. I'm sorry for the technical glitch, but you can reach me at, this is my email ID, and Ronalji, we are open to take any questions now. I'm going to stop sharing.
Does talking cool with the person who did a mistake won't encourage him to do it again?
So we are not talking about talking cool to the person. We are talking about, and thank you for that question. It does make sense what you said, that you're sort of, it's okay, that's fine. That is a very casual kind of talk. You feel that casual talk will definitely encourage more people to make mistakes, and you're right. I'm not talking about that. I'm telling that yes, action needs to be taken. We need to find out first why the mistake happened. The first is obviously you'll take a corrective action. You will do whatever needs to be done with the patient and try to do the damage control. But with the staff, there should be no knee-jerk reactions. You made a mistake. No, that cannot happen immediately. You have to do a root cause analysis, find out what happened, what triggered him to do the mistake, what was the ecosystem in which that error happened. Then sit down. And if the person is at fault, or if it was an oversight of the person, then the person needs to be told that. Not just that person, everybody working in the same cadre should be informed that this mistake happened with this person. Please be mindful that this mistake doesn't happen with you. So that has to be done. And that will help you. That will encourage that person to do the things correctly and not make mistakes. But imagine if you have a knee-jerk reaction and you're going to shout Mr. Athria to that person straight away, or even take a very harsh decision to get that person out of the job. What kind of environment or culture you're creating in the organization? You're creating a culture of fear, which we do not want. Because we are human beings. To err is human, and we can make mistakes. The best people can make mistakes. How we can learn from this mistake, examining the mistake, and setting in preventive actions is something which we need to understand. Obviously, if that person is recurring with the mistake, then the person will be put on a performance improvement plan and then action will be taken. But all this cannot be as a part of a knee-jerk reaction. That is what I wanted to say. I hope it makes sense.
Thank you. There is one more, but it's not a question, it's a kind of request. So, can you please share the incident report format?
I'll be very glad to share the incident reporting format. I will be happy to share the PREM questions also. If you want to start evaluating your own department, and because this work was done for cataract, I'll be happy to share those questions. You can start asking those questions to your cataract patients and learn about how safe your department is. If there is anything else, please let me know.
Okay. So again, a question from Swapnali Gogoi. Is adverse event reporting also a regulatory requirement in eye care?
Yes, Dr. Swapnil, especially if you are looking at complying with any accreditation standards. For example, if you want to comply with NABH standards, then that is a mandatory requirement that you report every adverse event. And like what I was telling, if an adverse event is not reported within 24 hours, that itself becomes an adverse event. So this kind of a webinar for an hour is not enough for any adverse event reporting kind of a training program. We understand that there's a constraint of time, and if there is enough and more enthusiasm for learning how to really do it and how we do it, I'll request our medical superintendent, Dr. Katyayani, to take a session next time on how it is done at our center in Bangalore and what we do. So we'll be very happy to come back to you and do it. But I really feel that it is a win-win situation if this culture is there. There is nothing, you gain nothing if you brush the adverse events under the carpet. It's only losing a lot of things. At the end, you lose the reputation. And that is a severe damage to the organization. So it is something to learn, something to go forward, and maybe reduce the adverse event, reduce the frequency of that, or do not make the same mistake at least again. But to expect that, oh, in my organization, I have zero adverse event, that is definitely not possible. And so this is what I wanted to say, that we should all get ready to accept this and have the humility to work on it.
If an employee hides faults and does not provide correct data, how can we ensure accurate and reliable information?
Yeah, Dhruvi, thanks for that question. So, Dhruvi, what we have to understand is that in any organization, there will be somebody who would be a crook. Okay. And we will all have to either you get the crook out eventually, or we'll have to learn to live with that crook. Okay. So in that case, the reliability of the information which that person gives will always be taken, will never be taken seriously. The growth of that person will always be affected. So the person who is suffering is that person himself. But if you find, Dhruvi, that that person is a habitual wrongdoer, then to keep such a person a rotten apple in the organization would not be the correct thing. it would not be safe for your organization. So then you will have to take the harsh decision and get the patient out of the organization. But definitely, you would want to give him a chance. You would want to train him. You would want to appeal to that inner, higher, spiritual self of that person before you make that harsh decision, because everybody deserves a chance.
Okay, so Dr. Samina, I do have a query. Like, if any of the individual employee who is trying to hide the faults and does not provide correct data, and because of that, I think if it is a regulatory requirement, definitely it may hamper to the organization's reputation, and in some context, they may attract some adverse scenario for the organizations as well. And if there is an employee who is doing regularly like this, how the organization would get to know that how the employee is hiding it, or that could be a very tricky for the organization to find out the person. So how should this be handled?
Correct me if I've understood your question correctly, Mrunalji. You are trying to say that if an adverse event happens and it never comes to your notice, or it is
Yes.
never brought to the notice of the organization, and the patient suffers silently. Now, the chance of this happening is really less, because there are other people also in the organization, right? And the patient
Yeah.
is going to come back to you, and the patient will report. But yes, you are right, and this can happen. So then, what I would want to say, that as a part of a risk reduction for such a thing to happen, the selection, or when you are hiring, your HR has to be very strong. You have to hire people with the cultural fit or the attitude fit rather than the skill fit. So skill fit is required, but an attitude fit and a cultural fit is required. And testing for that while you're hiring itself, be very cautious, do the background checks and see that this doesn't happen. But if this does happen even after that, then yeah, the organization will suffer. But I cannot imagine that this will go on for a longer time. Sooner or later, this person will be making another mistake, and the patient will complain, and you will get to know. But when you get to know, you'll have to go back and check whether any such mistakes have happened in the past also, and you will have to take
Mm.
action. No, meanwhile, I feel that I would like to again say that this is a need of the day, that adverse event reporting is done. And many organizations, they struggle about how do we go about it? How do we go about doing the root cause analysis? How do we go about setting preventive action? How to do 5I? And so, like what I said in the past in this webinar, a lot of efforts have been taken by the partner organization of SEVA Foundation. And with all their help, SEVA Foundation has put together a book on adverse event reporting. And I hope that as soon as this document is available to be shared, it is shared with all of you, and to share it with many more eye care organizations, so that they can learn from a ready reckoner format, and we can do this. Because we can understand that when something goes wrong, it is so painful. And together, we can reduce this pain in the world. We can make our world a little more safer place, our eye care a little more safer, and spread a little more happiness. Where so many things are going wrong, at least we should ensure that our hospitals are safer place where we only spread smiles. So this is what I wanted to say, and I want to again thank everybody. Thank Vision 2020, all the office bearers over there, and thank you, Mrunal ji, for moderating the session. Thank you, Gangadhar ji, for helping me out in the morning. And I'm again sorry for the technical glitch which happened on my end, but hoping to see you all again in many more such very interesting discussions, and to how to make eye care organizations safe. Thank you very much.
Thank you, Dr. Samina. This presentation was really insightful, and I'm sure that this will help the organizations to in many ways. I thank to all the attendees today who attended the webinar, and we appreciate your time, engagement, and thoughtful questions. A special thanks to our speaker, Dr. Samina, for sharing her expertise, knowledge, and experience. We also thank our CAB members for their support.